My name is Stuart Binstock. I am the president and CEO of CFMA. We are thrilled to be having this quarterly call of the Construction Industry Alliance for Suicide Prevention. We currently have 64 members of the Alliance. The growth has been tremendous over the last year, and we are thrilled to have so many of you on this call today. Without further ado, let me introduce Michelle Walker, who's the chair of the Alliance, to introduce Dr. Teeter.
Thanks, Stuart, and welcome everybody, and thanks so much for taking the time to call in today. I would like to introduce Dr. Dawn Teeter. I had the privilege of hearing Dr. Teeter's presentation a couple of months ago on the National Action Alliance for Suicide Prevention's Workplace Task Force call, and the information that he brought was amazing to me to learn. Some of the information about how opioids work, why addiction is so prevalent with opioids, kind of some of the clinical medical components of it, and then also just his insight on the employer's role in reducing opioid addiction and also the connection of opioids to suicide. And so I thought that his information would be very valuable for everyone. So thank you for joining in and listening to this today. Dr. Teeter is the owner of Teeter Health Solutions, who works with medical and governmental agencies to reduce opioid prescribing, improve pain treatment, prevent addiction, and increase access to medication-assisted treatment for those with opioid use disorder. He's also a physician at Meridian Behavioral Health Services. He's been a medical advisor to the National Safety Council, and he is also an expert panelist for the CDC in their guidelines for prescribing opioids. So he has just great history on this subject, and we're so thankful for him for his time today. So without further delay, Dr. Teeter, I'm going to turn it over to you.
I appreciate the chance to be able to share with you all. I've been doing this work for a long time now. My history is as a family practice doctor in the mountains of Western North Carolina. We began to see people becoming addicted to opioids nearly 20 years ago. You know, it's thought that this problem really began in the mountains here of the Appalachian Mountains. And about 15 years ago, I began treating opioid use disorder as a significant part of my practice, and I was really overwhelmed with patients. And I realized then how little I knew about pain, depression, opioids, how these are all related together, and how addiction fits into all of that. So I really began kind of on this journey on my own to figure out why this was happening and why my patients were becoming addicted. And I learned so much during this process. As Michelle mentioned, during that time, I became the medical advisor to the National Safety Council. So I've done a lot of work with employers addressing workplace issues, and I'm really glad to be able to talk about this today. So there's several things you really need to know, and one really is that this problem with opioids and with addiction and depression and suicide, all of this is very closely related. But in particular, opioids can be problematic for your employees, and there are several reasons for that. And one is they do increase your costs. They are impairing for people who are working while taking them. They are clearly addicting, as we all know. And they do certainly increase the risk of depression, and they increase the risk of suicide in folks. And I want to share a little bit on all these points during this webinar. First, I want to mention that these are problematic whether used illegitimately, if people are buying them on the street or getting them from the friends, but they're also a problem if they're used as prescribed by the doctor. So for those people that are illegitimately using them, that are abusing these and bringing them from home, they are clearly impairing. People using opioids in the workplace are impaired in a number of ways. One is they are not good at multitasking, so they can't do more than one thing at once. They don't react as quickly if there's a problem that develops. Their decision-making abilities is impaired, so it puts not only themselves but others that are working with them at risk. And people that take them illegitimately, it's almost certainly a sign of an opioid use disorder, which is our current term for opioid addiction. So there's different levels of opioid use disorder. There's mild, moderate, and severe, but the mild opioid use disorder are the people that are taking these recreationally. They're bringing them to work and taking them for whatever reason. And opioids are really this unique addicting substance in that once people start on these, it starts them down this path that's very hard to get off. And there's a number of reasons for that. That's really can be for another discussion another time. But they are problematic. But legitimate use is also problematic. And I want to be really clear about this because hopefully at the end, if we have some time, I'll share the case of a patient I recently had who was given opioids legitimately for a workplace injury, and it ended up resulting in his death. So when given legitimately, if you have an employee who has a workplace injury or has a non-workplace injury but is prescribed opioids by the doctor, again, they are impairing. So that's clearly problematic while they're at work. But even for those who don't work in safety-sensitive positions, it's problematic just driving to work and home. It increases their risk of a crash by a factor of 4. They're 4 times more likely to be in an accident, to cause an accident. As I mentioned, they are addicting. I think we all know this. I'll talk about that a little bit as we go on. Studies have shown that people that are injured at the workplace and are given a prescription for an opioid within the first 6 weeks of that injury, that prescription alone doubles their risk of being disabled 1 year later. And there's a number of reasons why this happens. We'll touch on this as we go on, but it's clearly a significant thing that opioids cause long-term bad effects. Studies have shown that use of opioids delay recovery after an injury or even after surgery. They increase medical costs, and interestingly, they are less effective than alternatives, whether used for acute pain or for chronic pain. So there's some better things we can do that'll help people have better outcomes. So I didn't understand this back when I used to prescribe opioids, but this is a really significant factor, how opioids are related to both depression and to pain. And there's this close connection between these 3 problems. And obviously with depression comes suicide. And again, I didn't really understand this, but the more study I've done on it, the more I've seen how all of these things affect the same areas of the brain and how they each are problematic when you talk about any of the others. So some things we know is people with depression actually suffer from more pain. If people have a chronic depression, they tend to have more pain. It's really a very significant correlation there. And people with chronic pain have more depression. So a study that I cite here showed that about half the people that have a chronic pain problem suffer from depression, compared to about 16% of people in the general population. So, that makes sense if you think about it. Chronic pain is something that is depressing. Again, there's ways by knowing how the brain works, how you can understand how these two go together very closely. But it's really dramatic. Again, almost 50% of people with depression, or almost 50% of people with chronic pain do have depression. If there's an individual who's injured on the workplace, if they have a workplace injury, their greatest risk factor for developing chronic pain is the mental status of the individual prior to the injury, in particular depression and or anxiety. Now, you would think that the risk of chronic pain would be related to the severity of the injury, but that in fact is not the case at all. In fact, there's almost no relation between the severity of the injury and the onset of chronic pain. It's more related to the status of the mental status of the individual prior to the injury. There are some other things that affect it as well. Work satisfaction is actually probably the second greatest risk factor. If you have an individual who does not like work after an injury, they are at greater risk of developing chronic pain and of not coming back to work and having a very large workers' comp claim. And interestingly enough, the use of opioids to treat pain is also a major factor in developing chronic pain. And as I mentioned before, opioids really work on the brain in this way that leads to depression and leads to chronic pain and leads to disability. Again, that's a whole nother talk. We can get into that more, but opioids are clearly problematic. If opioids are used to treat people with chronic pain, it increases the risk of depression by 50%. And if they're already depressed, it worsens depression. So one of the things you'll hear some pain doctors, in particular those who are being paid by the pharmaceutical industry, when they're talking about treating pain, they'll talk about how opioids are very important because of this risk that I mentioned above, that people with more pain have more depression. But the fact is, if those people are started on opioids, their depression gets worse and does not get better. And again, it has to do with the way these things affect the brain and even change the brain to make this depression significantly worse. So again, I say all this just to say there is this very close relationship between depression, between pain, and between opioids. So as we go on to talk about suicide, which is what you all are interested in, we know that the risk of suicide is increased with those with chronic pain. And we also know that the risk of suicide is increased with those with chronic pain who are on chronic opioid therapy. So again, it makes sense if the opioids are making them more depressed, that would increase their risk of suicide. Interestingly, another thing that increases your risk of suicide is the availability of a mechanism to actually commit suicide. So I think you all are very aware that if somebody is suicidal, we talk with their family members and say, make sure there's no guns in the house, or they have no access of a way to commit suicide. And in fact, opioids are a very common way to commit suicide. And by giving somebody with chronic pain who's already depressed opioids, not only are you making them more depressed, but you're also giving them the tool to commit suicide. In 2016, the last year we have data for, we know that 42,000 people in the United States died from an opioid overdose. And the fact is, we just don't know how many of those were intentional overdoses and suicides compared to unintentional. So in the majority of cases, somebody with chronic pain has opioids at home. They're found dead the next morning. Most people that overdose on opioids, they are found dead the following morning. They just don't wake up from their night's sleep. In most cases, unless they leave a suicide note, those cases are ruled as unintentional suicide deaths or unintentional opioid overdose deaths. So there's been a lot of work recently trying to figure out how we can find out how many more of these are intentional. But there's a concern and a thought that there's a significant number of these that are intentional overdose deaths. So I talked earlier about how acute opioid use after an injury can lead to chronic disability and chronic pain. This is a study that came out from the CDC within the past year, and they were looking at people that had not been on opioids, and they had either an acute injury or they had surgery. And then they received a prescription for an opioid following that injury or surgery. And they tried to look at the initial prescription that was given to them and look at the characteristics of that prescription to determine if there's anything with that acute prescription that led to long-term use. And so what they would do then is that they would look at the initial prescription, and then they would look at how long these people stayed on opioids. And what they found was that the bigger that first prescription was, the longer the duration of that first prescription, it increased the risk of them still being on opioids 1 year later and even 3 years later. And so you'll see on this slide that even a one-day prescription for an opioid after an injury gave people a 6% chance of still being on that drug a year later. And we know that opioids cause these changes to the brain, starting with the very first pill. And the longer that goes on, the more problematic that is. And so again, a 6% chance after a one-day prescription. If people are given an 8-day prescription, they have a 13% chance. And a 31-day prescription, they have about a 1 out of 3 chance of still being on them a year later. And this is, again, regardless of the severity of the injury or the surgery, but just to the opioid prescription. So this showed that the longer people are on these, the more likely they are to remain on these. And what we know is that opioids actually cause a change to the brain. They make it so that you feel less pain. So, for example, say somebody is injured at the workplace and they break their wrist, and they get medication for it. If they get ibuprofen or one of the similar medications, the nonsteroidal anti-inflammatories, those work by reducing inflammation wherever the trauma is, and that causes less pain. But opioids work in the brain, and they cause the brain to feel less pain. But our brains are these fantastic organisms, or organs, and they understand that we need to be feeling that pain. It's a defense mechanism. So they begin to make changes after the first dose of opioid to make us feel the pain more significantly. So you get a prescription for an opioid for 1 day. You take it for that day's period of time, and your pain goes down while you take it. But then when you come off, your pain is greater. And so then many people will call for more prescription and stay on it. If they get it for 8 days, then they come off and their pain is even greater than it was before. So the longer people are on it, the more these changes occur and the harder it is to get off of them. So what do we do for acute pain? There are alternatives. I mentioned before that opioids are not the best alternative. So these studies looked at people that actually are post-op after orthopedic surgery and looked at how well different pain medications treated pain. And their goal was 50% pain reduction. So what they found is that taking 200 milligrams of ibuprofen, 37% of people will have their pain reduced by 50% after an acute surgical procedure is done. And that's pretty good. So 200 milligrams of ibuprofen is 1 over-the-counter ibuprofen. 500 milligrams of acetaminophen, that's 1 extra strength Tylenol, and 28% of people will have their pain reduced by 50%. If you double that dose of ibuprofen and go up to 400 milligrams, the pain improvement only slightly increases. In 600 milligrams, it's only slightly more increased. So low doses of ibuprofen work very well for pain relief. Oxycodone 15 milligrams is a pretty strong dose of oxycodone, and only 21% of people got adequate pain relief with that. And I will also share with you, I don't have it on this graph, but looking at morphine, 10 milligrams of morphine given as an injection, and only 37% of people, similar to 1 ibuprofen. The next bar graph here will be the combination of oxycodone and acetaminophen, and this is roughly the equivalent of 2 5-milligram Percocet pills taken together. And it's no better than taking 1 over-the-counter ibuprofen at pain relief. In Europe, they combine ibuprofen and acetaminophen and give them together. In fact, they have a combination pill for that. And again, this is the equivalent of 1 over-the-counter ibuprofen, 1 extra strength Tylenol, and 62% of people get adequate pain relief. And again, studies have shown by avoiding the opioids, we have not only better pain relief, but we have improved recovery times, we have reduced infections, we have faster return to work. So this final combination is what I often recommend to people who have acute injuries or even have had surgery. So we do have options for acute pain, and that's non-opioid options. Chronic long-term opioid use is also very common. We think about 6% of the adult population takes opioids every day for chronic pain, and yet that's also problematic. Again, it's impairing, as I mentioned before. It's probably never appropriate in the workplace, and partially that's because of the impairment, but it's also because, again, these people just driving to work and back, they're at greater risk of having an accident and injury. Chronic long-term opioid use has been shown to increase pain instead of decreasing pain, and again, understanding how our brain changes to accommodate for the opioids, that makes sense. It increases depression. So initially, when you start on an opioid, if you have chronic pain and chronic depression, the depression actually gets better. But after you've been on it for about a month, that reverses and the depression becomes worse. And obviously, it increases your risk of suicide. So there are some things that can be done in the workplace. And to do this, we need to really look at our drug-free workplace policies and how they're structured. So historically, drug-free workplace policies came about during the Reagan administration with the war on drugs. And it was really the purpose of the drug-free workplace policy was to identify people taking drugs illegally or illicitly, identifying those people, and usually, they're fired from their job, but it's meant to be a negative or a deterrent for illegal drug use if people are working. But with only some slight changes to our drug-free workplace policies, we can make it so that they now become a safety and a health tool for our workers. So doing appropriate drug testing can actually be a deterrent from people experimenting with illicit drugs, and it can keep them safe and reduce long-term problems. So what are some of the things that can be done? First of all, occupational medicine doctors have historically prescribed a lot of opioids. There's actually some changes to that, and their professional organization is making some recommendations that we greatly reduce opioid prescribing. But in different states, there's different workers' comp laws and workplace laws as far as who you can refer your folks to after an injury. But if you have any control over that, you need to be talking to your doctors and try to reduce their opioid prescribing. And you need to update your drug-free workplace policies. So there's several things that needs to be done. And one is you need to make sure you're doing random urine drug screens on all employees in safety-sensitive positions. Again, it works as a deterrent, but also it will identify people if they're starting down with a drug problem. And along with this, you need to do several other things. You need to make sure that your drug screen is testing for the right drugs that are commonly abused in your area. The historic 5-panel test that's been done for many, many years does not test for oxycodone, which is the most abused drug in the United States now. So make sure you're testing for the right drugs that are used in your area, and that the other thing is people in safety-sensitive positions need to report to you if they get a prescription for safety purposes for one of these drugs so that they can be put in an alternative working solution that's safe for them. People that have a positive test need to be referred to an employee assistance program that can evaluate and treat opioid use disorder. So opioid use disorder is really a special kind of addiction. The typical abstinence-based treatment usually does not work. People actually that go into an abstinence-based program are 5 times greater risk of dying than people that are treated with medications. And use the policy to educate your employees about the dangers of opioids. I mean, have them be able to speak with their physician saying, I don't want the opioids for myself or for my family. Let's use alternatives that may work better. So I'm about run out of time. I won't get into Jim's story. Jim's a real patient of mine I had recently who had a workplace injury. He fractured his ankle. He worked in a safety-sensitive position. He went to his doctor. He had surgery, but he was put on opioids for 3 months. After that, he just could not get off of them. He continued to buy them on the street. He would go to his doctor once a month and say he had back pain, was given a prescription. When he did test positive, the medical review officer saw that he had a legitimate prescription and called it a negative test. That's something that should not be done. The medical review officer should be notifying you so that you can intervene if necessary. He was never referred to an EAP. When he was finally discovered shooting up oxycodone in the bathroom, he was fired. Because of that, he got very depressed. And he overdosed a short time later. And his wife at his funeral told me that she thought his overdose was from was a suicide because of his depression that resulted from not just his addiction but also losing his job. So there's several things that could have been done to save his life. Limited opioids after his injury, 3 days or less is what the CDC recommends. No opioids in safety-sensitive positions. You know, if he would have been testing positive, regardless if he had a prescription or not, that would have been addressed. And an appropriate EAP referral instead of just firing would have also probably saved his life. So just to finish up, this is a common quote. I hear this all the time. This actually comes out of the American Society of Addiction Medicine, Principles of Addiction Medicine. This is their textbook. And it says opioids are the most potent medications we have for treatment of pain. In fact, there's no data that supports that. And the studies we have actually support that they are probably the least potent medications we have for either acute or chronic pain, and that there's other things that need to be done. So that's my contact information. I will be glad to take some questions. And let me just also say in the future, if you want to contact me with any questions about your organization, I would certainly be glad to work with you.
Thank you, Don. Christy, if I could just ask one question before you jump in with others from the group. Yes, Don, on the last time I heard you, you discussed the difference in individuals that received a prescription later than the first day after pain, so like a day 1 after an injury versus subsequent days, so, and the difference in addiction with that.
Yeah, so there is some relationship between when they get the prescription and how likely they are to become addicted as time goes on, and actually that relationship goes out as far as 6 weeks after their initial injury. So if they get a prescription anytime in the first 6 weeks, that becomes more significant. And it's unclear if there's a difference really between 1 day and 5 days and 6 days, but just to know that that risk does continue as time goes on. I mentioned the duration of that first prescription is significant. Also, the medication that is prescribed is very significant. So many physicians think that tramadol or Ultram is like the mildest and the safest of the opioid medications, but in fact, it is the one that increased the risk of future addiction more than anything else. So there seems to be no relation, or there seems to be some drugs that aren't as safe as others. Morphine actually might be the safest of the opioids to use after acute injury, but still there's a very significant ongoing possibility of developing addiction, even after that first dose. And so, you know, I will share with you much of what I do now is both addiction treatment and chronic pain treatment. And many people I hear in my addiction treatment will tell me that they thought they were addicted to their opioid after that very first dose. They took the first one, it just made them feel better, it calmed them down, it reduced whatever stress was going on in their life, and they continued on them. So I really believe even that very first pill can be problematic.
Okay, this is Christy at McCoy's. I have a question here. If the Tylenol-Advil combo is so much more effective than opioids, then why are they never prescribed?
Yeah, so that's a good question. So a lot of that is because we were never taught that in medical school. So when I was at the National Safety Council, we actually did a poll with primary care doctors, and we had, I think, about 8 different medications and medication combinations, and we asked doctors what they thought the most effective for pain treatment was. And about 80% of them picked one of the opioid alternatives, either morphine or the oxycodone or the oxycodone acetaminophen combination. Only 1% of respondents picked that combination of ibuprofen and acetaminophen as the most likely, as the most effective. And it's just because we were never taught that. Again, I never heard that anywhere. In fact, we receive almost no education on pain treatment in medical school. The way we learn is just by doing our rotations with doctors. And say we're working with a surgeon, and the surgeon says, okay, discharge this patient, give them 30 Percocets. And so that's just kind of what we learn, what other doctors have done. And, you know, physicians have been using opioids for over 5,000 years now. So that's just kind of been handed down. But this newer information is just not out there yet. There was a study recently looking at how long it takes information once it's discovered to really make it to be routine practice in the medical community. And it showed that from the time of a discovery until something is routine practice is about 17 years. So we just are not good at incorporating new information into how we practice medicine. And this is one of those things. It had no pharmaceutical industry backing that showed that the acetaminophen and ibuprofen was better. So there's no one really telling the doctors about it. So it's just not known. They were not taught that. We just think opioids are more powerful. You know, we've seen people in the hospital that have severe pain, and you give them enough morphine until they basically fall asleep, which is fine in the hospital where you have them monitored and you can do what you need to keep them breathing. But if that happens at home, obviously that's problematic. So, you know, we're just not taught that. We just don't know it. You know, again, I will share with you, much of what I do now is educating prescribers and providers, and they love to hear this message. And you know, they learn that they don't need to use as many opioids, and they change very quickly, because most people have had patients that have had bad outcomes with the opioids, and to learn there's an alternative, it's very, it makes them very happy.
Great, thank you. We have a couple more questions here. So comments on a great presentation, and you mentioned that updating your substance programs. What experience do you have in working with union contractors where substance abuse programs are a mandatory subject of collective bargaining?
So I don't have a lot. You know, most of my experience in that came with when I was at the National Safety Council, and they actually they have an kind of a subgroup that works with the unions. And you know, one of the things I really kind of struggled with was helping the unions understand that again, a drug-free workplace policy done right actually protects the worker and is not punitive, because they really have this impression that the drug-free workplace policies are punitive. They're very resistant to any drug testing and to any actions being taken. So, you know, directly with the negotiations, I haven't had any experience, but just talking with the unions, I've found it to be, let's say, challenging, if that answers your question. You know, I would just say I would be glad to offer my services and to show how this works. And you can go on the National Safety Council site. They've got some information there about how to work with unions and talk about this and how to develop your workplace policies. Some of it is several years old, but it's still pretty good. So that can be one resource for you. Again, I would be glad to you know, provide some documentation or do whatever I can with those negotiations.
That'd be great, thank you. Next question. One person has a really bad reaction to the opioids. Why do they not work for some and are addictive for others?
So that's a question we don't really understand a whole lot yet. There are some ideas. So we think some people clearly have a genetic susceptibility to developing addiction when they get an opioid. It's hard to predict that unless there's a pretty strong family history. You know, I will share with you, I have a brother who suffers from addiction. I do not. We compare our first experience when we were both like 14 years old and the first beer we drank, and he remembers it as the best experience of his life up until that point. And I remember it as feeling a little bit weird that I was a little bit out of control. So we had this completely different reaction. That's probably the genetic aspect of it. We know that people that have had difficult childhoods, so there's a study called the Adverse Childhood Experiences Study that looked at kids that are in homes where the parents are divorced or separated, where one parent goes to jail, where there's drug use as a kid, where they're abused, where one of their parents was abused. And it showed that kids that grow up in these situations that are experiencing these adverse childhood events are at higher risk. And we think that the kids that are in these difficult homes, they actually have brain changes that become permanent that make them suffer from more anxiety later on, more depression later on, and actually makes them more susceptible to drug use. So two of the biggest things are probably genetics and children that grow up with these adverse childhood experiences. And incidentally, you know, I mentioned one of those experiences can be if your parent goes to jail. One of the things we're doing with our current drug programs is that if we're arresting somebody for a drug use charge and they're going to jail, it's about doubling their child's risk of developing addiction in the future just by sending that parent to jail. So, you know, there's a number of things we need to reevaluate. So those are probably the two biggest things. People that just have general stress, people that are under a lot of stress, actually the medical community has been shown to be at the highest risk of developing opioid use disorder. And some of that is thought to be because of the stress. And let me just mention the fourth thing can be exposure. We know that children that are given an opioid prescription legitimately before the age of 18, it increases their risk of future drug abuse and addiction by 30%. So just because they're exposed to it, it causes these brain changes that increases the risk. So that can be problematic as well. But to be honest with you, there's a lot of folks that they just don't seem to have any risk factors and they get addicted anyway.
Thank you, Don. So there's a comment here, maybe not a question, but just something about the industry. So it's challenging enough to get the employees back to work in the environment where the work may not be readily available. So what do you do in that instance?
Right. So, you know, I clearly believe that getting people back to work as soon as possible probably decreases their risk of chronic pain and future addiction. And that might mean having them come back and empty trash cans in the office, or, you know, just be at work doing whatever, going through files or forms or something. So, you know, if somebody's in the construction industry and they have a difficult, strenuous type job, you know, that might not be ideal for them to go back to work right away after a back injury, say, but getting them back to work to do something is helpful and has been shown to be more successful. So whatever you can find them to do to get them back to work. You know, our current recommendation for back injuries and back pain is that people should stay mobile. They shouldn't be staying in bed. They shouldn't be staying at home. So it actually helps their recovery if you can get them out, whatever that is.
Okay, great, thank you. I think that wraps up the questions we have so far, but there was a question about whether this presentation and recording will be available, and yes, Don's allowed us to send the presentation out, and there will be a recording, so we'll be sure to get that out to everyone.
Thanks, Christy, and thank you so much, Don, for your time and your just the information, and I hope that this has been valuable to everybody else on the call. And just thank you for making yourself available for both presenting and then for follow-up questions after. And
You're welcome.
I can speak firsthand. He responds right away and is very helpful following these calls. So thank you so much, Don.